Our first question comes from Seamus Fernandez with Guggenheim. Your line is open.
Oh, thanks very much. So congratulations on the data, guys. So just a couple of quick clinical questions. First, Roman, I was just hoping that you could clarify that the endpoint of a loss of 80% is consistent with the other labels. I believe most of the other labels were a comment that it's a return to baseline. So just wanted to clarify that as the sort of standard endpoint to claim the return to baseline. The second question is, it looks like in terms of the effect, the majority of patients who certainly saw an effect maintained that benefit out to 12 weeks, 10 to 12 weeks. So just wondering if my look at just the curves in the data are consistent in that regard, and perhaps if we were to overlay the curves from some other therapies, where that break actually begins. Is it typically at as early as 8 weeks? And then the last question, just wanted to, Mark, have an understanding of when, given how powerful and robust these data are, is a second trial likely to be required for this patient population? I believe that is the case, but just wanted to follow up on that question. Thanks.
Sure. So thanks for the question. I'll take them in order and then pass it over to Mark. So in terms of the endpoints that are used in the other phase 3 trials, they have evolved over time. So, for example, the Botox endpoint, which was the product was approved back in 2000, it used a completely different scale to evaluate efficacy, the CDSS scale, or cervical dystonia severity scale. However, all of the neurotoxins, whether they be type A or type B, subsequently did use the Twisters assessment to evaluate efficacy at the primary endpoint. So that evaluation of the primary endpoint looked at the improvement in the total Twister score from baseline at the primary endpoint time point, which in most of the other studies is at 4 weeks. The primary endpoint, however, does differ from the duration of effect and how it's measured. The duration of effect does differ from phase 3 program to phase 3 program. In other words, some evaluated it in terms of return to baseline, which would lengthen the duration of effect timing that's reported in their papers. Of note, ours is defined by the loss of at least 80% of the treatment effect, so our patients were not allowed to return back to baseline before they exited the study. And this is consistent with the current standard of care, which calls for treatment before patients return back to baseline. So you'll see slight differences in the labels in terms of how they characterize duration, whether it be return to baseline status or time between retreatments. They all of these duration definitions are consistent with how the original study was designed. We did, as I mentioned, evaluate duration by time to loss of the peak treatment effect, and we're able to achieve 20 to 24 weeks for the 2 doses. In terms of the second question that you asked, the drop in the peak treatment effect, if we look at the Kaplan-Meier curve, so that would be back on 14. On slide 14. That curve, I think, is probably the most helpful to be able to understand the difference in terms of the drop off of the treatment effect. And what you can see for the DAXI curve, if you look at week 12 and go up to the percent of subjects who have lost 80% of the peak treatment effect, you'll see about 5%. Only 5% have lost 80% of the treatment effect. That's in stark contrast to the competitors. If you look at the Kaplan-Meier curve on the right, you can see that at week 12 for MyoBlock, the 50% of the patients have lost the peak treatment effect for Botox. That occurs at week 14. And as I mentioned earlier, this is for a population of responders. So our product appears and performs very favorably in terms of duration of effect and the maintenance of that as described by the Kaplan-Meier curves.
And then Rome, why don't you go and take the third one as well in terms of another trial?
So prior to initiating the ASPEN phase 3 program, we did meet with the FDA as is customary, and they have approved the design of our pivotal program to include only one pivotal study as well as one open-label safety study. And as Mark mentioned, the open-label safety study will read out next year in 2021.
Thanks, Seamus.
Thanks, guys.
Thank you. Our next question comes from David Amsellem with Piper Sandler. Your line is open.
Hey, thanks. So just a couple. First, a question for Roman. Can you talk about the absence of a dose-response relationship? It looks like the lower dose did better on duration and just on the primary. So, any color on what may be happening there? That's number one. And then the second question is more of a question for Mark, and just we talked about this before in terms of commercialization, but given what you've seen in the data, does it make it more likely that you